So really, this is about creating caring communities. And how do we make that happen? We work to make conversations about serious illness a normal part of everyday life, and palliative care a normal part of everyday health care. So conversations around the kitchen table, the water cooler, places of worship, senior centers, on the radio, social media, Netflix, anywhere and everywhere that people talk, making serious illness part of the topics that get discussed. And I think as Charles so eloquently talked to us about this morning, creating palliative care, a full and complete system of palliative care, so that it's seamlessly integrated across healthcare wherever and whenever it happens. Whether it's basic palliative care from your primary care provider or referral to a specialty team when needed. And received from the point of diagnosis. And one day, it'll start being provided from the point of birth, because once you're born, you get the diagnosis of being mortal, so palliative care is relevant. So what will the world look like in the future? Once we reach this point, what will we have? We'll have healthcare professionals who are trained in having conversations about serious illness, soliciting patient preferences, navigating these discussions with sensitivity and presence, all in a way that seems natural and a part of everyday health care. They'll identify patients who would benefit from palliative care and provide that palliative care and refer out if those symptoms can't be met. Healthcare organizations will have developed and put systems in place so that patients who would benefit from these conversations about serious illness have the opportunity to do so with a skilled professional. They'll have structures in place to track and honor patients' preferences, as well as identify, support, and address the palliative care needs of all patients. They will be HROs, highly reliable organizations when it comes to palliative care. The people can rely on them to do this consistently with the highest quality. For patients, they'll get the information that they need, they'll have time to think about it on their schedule, and they'll have the support to make the best decision possible in accordance with who they uniquely are. They'll be able to live the highest quality of life on their own terms, despite the fact that they're dealing with a serious illness. And family members will no longer be guessing about their loved one's wishes. They will be supported by their medical team and community. And when a loved one passes away, they'll know that they supported their loved one in the best way possible. Our laws, policies, and reimbursement structures will support conversations about serious illness, as well as the provision of palliative care for those who need it. Preferences will be documented and communicated at the right time that information is needed and honored. And all people will know what serious illness looks like, as well as high-quality palliative care. And they'll come to expect it. It will be the norm. So how do we get to that ambitious vision of the future? As I was thinking about it, I thought, what else has happened in the past that we might be able to learn from? So I did some research about the birth movement, which is another health issue that is a natural part of everyday life, but has become very highly medicalized, to the point that it seemed a little bit ridiculous. I read about women receiving so much pain medication that they had to wear helmets because the pain medication made them hit their heads. So it's kind of starting to lose a little bit of perspective in the treatment. And the movement also interfaced with the fact that women were really wanting to take back control over their bodies and their relationship with their children. It was a multi-generational movement. I often hear, it was the baby boomers that changed birth. I'm a baby boomer. I'm here to tell you it wasn't just the baby boomers. Writings about natural birth date back to the 30s. And it was really the women who gave birth to the baby boomers who were the ones that started that movement of asking for a natural birth with as little pain and medication as possible. So, and it was in the 50s that Lamaze was developed and brought to the U.S. It was in the 60s and 70s, mid-60s on up, it was the baby boomers that really took this and drove it home, creating a lot more aspects to the birth movement of reducing medical interventions, presence of midwives, using massage, giving birth underwater, standing up and walking around, the presence and participation of fathers, single, separate, standalone facilities dedicated to birth or labor and recovery units. A lot of that really started to become standard when the baby boomers were giving birth. But I have news to tell you, when I went online and I looked up, natural childbirth, there was a lot of critics of it. So the work is still not done. Not every person is having the information and support that they need to have the birth that they want and being fully supported. So this started with the greatest generation, through the baby boomers, the Gen Xers and the millennials are still carrying the torch. And it's gone by different names over time, from natural birth, alternative birth, and the newest one I heard now is positive birth. And that's a movement starting out of the UK of young women getting together around cake and coffee in homes and talking about different aspects related to birth. So these movements do take longer than we realize. So let's apply some of that to our movement here with serious illness and end of life. Are there some analogies? Certainly, early writings about the movement started in the 70s, including Eric Cassell, who was our keynote speaker last year, who wrote about the medicine, the practice of medicine, and the nature of suffering. Elizabeth Kubler-Ross, writing on death and dying. Karen Ann Quinlan was in the media, so it really brought our attention to the forefront. What we see happening right now is the greatest generation is teaching us about aging, serious illness, and dying. The baby boomers are aging and starting to experience some serious chronic conditions, and they have different expectations and different demands on the health system. And those voices we know, because of the size of the baby boom generation, is loud and getting louder. But our Gen Xers and our millennials have a role as well. Many of them are caregivers for a family member, whether it's a grandparent or a parent with a condition or a sibling. Many of them are used to reality TV and nothing is taboo, and their sense of privacy is different. So they have a huge role in this movement as well, which has gone by different names. Remember when we used to talk about right to die, death and dying, palliative care, serious illness? I think there's different names because it's a long process over time, and there's different aspects of it that kind of come to the forefront at any particular time. So what are some of the lessons from the birth movement and what we've seen so far in the serious illness movement? We see that it takes a long time and a sustained effort. We've made a significant changes, but there's still a long way to go. And that it crosses over multiple generations. There's periods of more obvious progress, and we can recognize it's still important to recognize that that's building off of what went before. We wouldn't be able to make those bigger leaps without the work that had gone before. There are prior accomplishments and prior leaders. And when we have that opportunity, we want to leverage that opportunity and take it as far as we can to make as much progress. A few years ago, there was a big shift in our work. And that's about the time that the Accountable Care Act came out and healthcare reform was big. And I know we've had some twists and turns along that journey with that law. But that time, the healthcare system really, these issues went from just being held by the true believers up to the C-suite, the CEO, the CFO, the CMO, the CNO. All of a sudden, it became on their radar screen. And that's what Charles was talking about here at kind of a middle of the pack health system saying, yeah, this is just what we do. The public also has recently shown much more interest in understanding and talking about these issues. We see it covered in the media, in social media, books and movies. We're going to have another one tonight, and they're just increasing. So we want to leverage this time that we have right now, this very special time of high interest. But we also need to recognize this isn't going to last forever. And when it's gone, our work may not, it's not that our work will necessarily be done. We have a lot to transition right now. There's a lot of, we've made significant progress, but there's issues around access, quality, consistency, and reliability. And that takes kind of a different strategy and a different energy sometimes than the early days, as Charles was talking about, when we were just the individual outsiders championing this. We need leaders to continue the work even in the quiet times and to hold the course. And don't get lulled into thinking we've crossed the finish line. I say as a society, we probably feel this a lot right now. There's a lot of movements that happened kind of coming out of the 60s, the civil rights movement, the feminist movement. And we're seeing a lot of things happen right now on the national political level that I think a lot of us kind of felt, didn't we do that before? Didn't we deal with this? Didn't we address it? Why am I still picketing here so many years later? But the reality is that it's like an onion, and as a society, we're peeling back the layers. And we got down a first few layers, but these new tensions that are on the table are the opportunity to go in deeper. Ultimately, all of this is about bringing in a new evolution, not just about serious illness, but what it means to be a human. And there's power in the masses. So what will it take, again, to get down to this deeper level of transformation? There's two factors that are really critical in the dynamics here. Demand, which is public empowerment, essentially, is people believing, knowing, and expecting that there's a better way. Having a vision and holding that, as well as taking action and steps towards it. So just wanting something different but not having any ability to act is only half of it. And that action could be as simple as asking for it. And I think in some ways the End of Life Option Act, what it did is it legitimized for a lot of patients, I can ask for something here. It could take the form of picketing, taking matters into your own hands and just talking to your loved ones. Don't wait for the healthcare system. And that demand feeds off of supply. And supply is the healthcare system and professionals behaving differently. We want the demand to shift that, to change the policies, procedures, the systems. We need educated and trained staff. We need structure and capacity. The status quo is pretty strong in healthcare. And lots of energy has gone into creating this system. We have physical buildings that we have investments in. We have equipment that we have investments in. We have such a wide range of treatment options that have been developed and that have been tested and that have been researched. We have the workflow for providing health care, as well as documentation, reimbursement, institutional policies, procedures, and public policy all playing a role. The list goes on and on. And that's why we need demand to create the pressure on the supply part of the system. Demand is what we need to kind of knock the supply a little bit off of its base where it is and adjust course a little bit. Because the supply part of our community or our culture is designed to keep going the way that it is. And it's going to take a lot of effort. Unlike birth, which had a discrete patient population, women of a certain age, that can be objectively identified, that was fairly common and consistent in the path that the birth process takes, with common milestones and a large but finite number of options. And that from start to finish, the process is 9 months. And you can see how long the birth movement, in reality, you see the kind of the tip of the iceberg, but what's underneath it is much bigger than we may realize. So with serious illness and death, it's going to take an even more sustained and coordinated and committed movement because the variation is so much larger. And there's really no bounds on the patient population. We are all mortal, and we all, even if we're not facing it, we know somebody. Even if we think we're not going to die, we do know other people die. And the path and the length of time on that is just so variable. And it really kind of the work we're doing kind of highlights some of the mismatch we have at the very core of healthcare. And that's why we need one more piece to make this happen. You can see the two. Oh, there you've got the movement going on. Movement and moving. So demand and supply playing off of each other. Movement here is depicted as kind of a platform or a structure, a stability providing direction and momentum so that supply and demand aren't just spinning around but ultimately move forward. You could show movement as kind of growing over time and getting larger and larger. Or you could even show movements like taking up the whole slide and demand and supply are embedded in it. But however you want to look at it, movement is going to help us move farther, faster. And it's going to address some of those tensions on the table, like quality and consistency. So with movement, we can share a common vision, common language, lessons about what works, building off of each other and creating synergy, not just an additive effect, but a multiplier, and take successes to scale. It's really the community of true believers. And we will need to fend off naysayers or disbelievers or detractors. So the Coalition's job, the Coalition for Compassionate Care, it's our job to be the platform where everyone can come together to create something bigger than we can create on our own. Our job is to serve as ground zero and the home for this movement with a focus in California. So looking at this, you might say, well, that's nice. I get the concept, nice model. But it's pretty abstract. So how does it work in the real world? Well, I think one of the greatest examples we have is the process of bringing PULSed to the state of California. It took a lot of collective effort, and it made a tremendous change. If you're not familiar, PULSed, Physician Orders for Life-Sustaining Treatment, is the pink form for documenting people's wishes when they're roughly about a year out. You wouldn't be surprised if they died, to turn their advance directive into a medical order. And by working together in 5 years, there was deep and wide penetration of PULSed throughout the state, and using PULSed to document treatment wishes of seriously ill patients had become an expected part of the standard practice. And we got there by creating, on the demand side, we created materials and resources for patients to be informed about PULSed and how they could achieve their goals. We created information and disseminated information and materials and resources to our healthcare providers, to the supply side. Training, policies and procedures, tools. We did a lot of things to get Pulse known and the uptake to occur. And on the movement side, we created standardization through legislation, a single form for the state, standardized training, uniform messaging, and quality measures. And we leveraged local coalitions and leaders to spread information, knowledge, and standards about Pulse throughout the state. So with all those elements playing off of each other of demand, supply, and movement, if we hadn't done it that way, Pulse would not have moved as fast and as well and as smoothly as it did in California. Now, I acknowledge, Pulse is not perfect, and there are still some bigger challenges in moving it forward. But it is an example of how this can apply. And how we've used this model in California does make some other states a bit jealous. So thinking back to the first summit, which occurred just a few months after Pulse became law, we were deep in the thick of it, of developing the standardized training. 17 communities had just received grants. And we were in the process of creating those model policies and procedures. And we had piloted through a project known as Prepared. Some of you may know that, piloted up in Sacramento through work by Catherine McGregor. What else was the coalition working on? We had also recently produced Thinking Ahead, which is an advanced directive workbook and advanced directive form developed by and for people with developmental disabilities to help them stay in control of their care up to and through the very end. And the Children's Hospice and Palliative Care Coalition had recently gotten the Nick Snow Act passed, which created the Partners for Children program. The legislation turned into a waiver, if anybody wants policy geeks out there, and the waiver turned into the program that allows kids to get palliative care and curative care simultaneously through Medi-Cal. The Partners for Parent website had recently been put up, so parents who were dealing with a seriously ill child could go online on their own time and find some answers and support. So we've come a long way in the last 10 years, and I'm looking forward to the next 10. But first I'm going to just go through some of the highlights of what has happened in the past year, since our last summit. Last year, we did talk about the California Advanced Illness Collaborative Consensus Standards for Community-Based Palliative Care. Those have been formally released, incorporating the comments, the feedback that we had, and now we're in the process of setting up a pilot in Sacramento and LA to determine if having these kind of consensus standards help with scaling palliative care, community-based palliative care. The Pulse e-registry has been going on for a bit of time, but in the past year we have started, the pilot has started to roll out in 2 communities in Contra Costa and San Diego. The End of Life Option Act has been in law for about a year and a half. And the coalition, along with UCSF and UCLA, we held a convening last September to look at what are some of the lessons and learnings from the End of Life Option Act. UCSF is in the process of conducting ethnographic interviews with patients and family members to understand their experience. And UCLA is conducting a survey of health systems about their policies and procedures related to implementation of the Act. We're also continuing to look at capacity. Capacity continues to be a challenge. It's much more gray than black and white. And through our work with the developmental disabilities community, we've become familiar with the concept of supported decision-making, which complements shared decision-making and surrogate decision-making. I don't know why they all start with an S, but they do. And supported decision-making is based on the belief that people are able to make decisions. Then making decisions is a learned skill, and it's natural to turn to other people to help, to solicit their help, but that the individual should retain the right to make their own decisions. And so we were looking at testing this concept out with bioethicists here in California and nationally to see how that responded with bioethicists, and that was funded through the WITH Foundation. We found a lot of interest and support, but it's still a very new concept, so also a lot of concerns. We produced various toolkits to help with engaging the public, including the Road Ahead, which was presented in one of our breakouts this morning, a toolkit for engaging faith leaders in your community, and we're releasing a new one for using Endgame, the movie that we're going to see tonight, in a community setting. We have our local coalitions throughout the state continue to go strong. Some have gone a little quiet, some are in hibernation, but many of them are still very active. And we've had the opportunity through a partnership and funding from Partnership Health Plan to specifically recruit and spear the creation of coalitions in Humboldt, Lake, Siskiyou, and Yolo counties. Of course, our website is still a great resource for people. There's a tool that we developed with CSU Institute for Palliative Care, an ebook that you can download on advanced care planning. And we serve as a neutral resource on the End of Life Option Act, as well as a resource for advanced care planning and palliative care. And we're active on social media and communication. We continue to do a lot of education, whether it's through live trainings or webinars, both for the adult population and pediatrics, and go out and do a lot of presentations throughout the state. A lot of you around the state are doing great work, and many are using the coalition to help them in one way or another, whether it's just using our tools and our resources and our website, or whether it's actively creating training together, having us do training, having us help you with implementation. So I really want to do a shout out to all of these, particularly UCLA and Partnership Health Plan. Also in this last year, SB 1004 has moved forward further. This was a law that was passed a few years ago that essentially requires Medi-Cal managed care plans to provide access to palliative care. And it required the state to figure out what does that mean and how does that happen. And it's been a little bit of a circuitous process, but the state has worked on it, and sometimes we'd like to play off of that in helping to create the political pressure to maintain this as a priority. And we partnered with about 7 organizations last year, including the Alliance of Catholic Healthcare and Providence Health System, the California Medical Association, California Hospital Association, to lobby the legislature. This was kind of getting put into a holding pattern because of budget limitations at the state, and we got the legislature, to kick it out of that process and to let DHCS, the Department of Healthcare Services, know this is a priority and keep it moving along. So it officially went into law January 1st. Now, is every person who's on Medi-Cal that could benefit from palliative care going to be receiving community-based palliative care immediately? No, because we don't have the capacity. So there's still a large ramping up process, but this puts us way ahead of most other states. And SB 1004 and the CAIC consensus standards parallel each other, one going through the state and Medi-Cal, the other through every other, relevant to every other health plan, and a way to keep us all moving forward consistently. And I really want to do a shout out to California Healthcare Foundation for the whole series of trainings that they did for providers and payers to help them get up to speed and prepared for SB 1004, and for CSU Institute for Palliative Care for the resources that they have online, again, to help providers getting educated and train on palliative care. We had a lot happen on the policy level this last year. We co-sponsored SB 294 with CHAPCA, California Hospice and Palliative Care Association, which clarifies and allows hospices to provide the full range of palliative care services. AB 937, you can see Carl Steinberg, a picture of him going to the legislature to lobby on behalf of the coalition in opposition to this bill. It's highly unusual that we ever oppose a bill. We are a coalition and we have members that have all sorts of positions, but we felt that this bill, while well-intended, would actually really create problems for POLST and derail it. And we worked closely with the California Medical Association on that, and it did get delayed last year. It may still move forward this year. We're kind of waiting to see. We haven't heard from the author what her plans are. But I would say our track record on a policy front is quite excellent, considering that we don't have a PAC and we don't even have a lobbyist. A PAC is a political action committee, and that's how most organizations buy. Oh, they don't, I didn't say that. A PAC does help you with getting the attention of very important people. And of course, lobbyists help you because they're in the building every single day, so you know what's going on and can keep you apprised. So it's through our commitment and dedication to the best care and practices possible for patients and working in relationship with all the stakeholders that we're able to do this. On the pediatric side, Devin Dabbs, who heads up our pediatric work, has been working diligently with the state on the renewal of the Partners for Children waiver. And there's been a lot of bumps along the way. So if you are interested in that, I encourage you to talk to Devin. And we always try to keep you up to date with what's happening on a policy front for those who are interested. So kind of in the next year, what can you be looking forward to? More work with our local coalitions. We're going to be doing a survey to kind of get a better sense of what's going on and what are the models that are out there and how can we provide you support. What are success traits and leadership that's needed for success? We're going to be using our e-patients, who are patients who are engaged and empowered in their care, often online through providing leadership through social media platforms. We have a grant from PCORI to develop some of the e-patients as ambassadors for palliative care. We're going to be developing a pediatric palliative care curriculum with CSU Institute for Palliative Care. We're going to be looking at best practices for concurrent care, which is the way for pediatrics, which is through the ACA, payment for curative and palliative care simultaneously. And we're also going to be looking at our membership benefits and how we can enhance that for all of you. So if we look at the coalition as an organization and kind of what is the evolution of the coalition, you can look at it as being in 3 acts. And in Act 1, we were just a grant from the Robert Wood Johnson Foundation and a project, grant-funded project of the California Hospital Association, and we were just brand new, and we were kind of figuring out, like, what could we do in this space? And completing that grant and achieving our objectives, we showed that we could accomplish something together with bringing all the stakeholders together. But we knew that when it was done, that our larger goal of really changing things hadn't been reached. Act 2, for me, is really symbolized by POLST. And that was the largest, most coordinated, well-funded, and staffed project that we had. And we showed through the use of POLST and bringing it to California that we really, when we work together, we can have a big impact. We don't just accomplish something, we accomplish big things. But Act 3, which is what we're in right now, how do we transition to this new opportunity of a lot more interest, a lot more activity? And how do we continue to bring in all the stakeholders as they grow? And how do we prioritize our time? We think that we have the pieces in place. We have the knowledge, we have the know-how, we have the track record, that we can realize the potential of the movement that we all visualize happening to create the future that we all want. But in this third phase, we need your help. It's really 1,000 points of opportunity, and that's what we want to leverage. Because as we go into the third act, some of the enthusiasm of the early days, sometimes it feels like it's waning a little bit. We accomplished quite a lot with Pulse, but there's still a lot more work to be done. There's issues around quality, the quality of the conversation, the quality of the form completion, how well is it being implemented, if we created this deep cultural shift that we all want. So there's still lots of work to be done for our work. But also we need to take care of ourselves and make sure we are all a resource for this movement, and we want to make sure we don't burn out. And for the coalition, there's a funding mismatch. About 3/4 of our money comes from grants, and grants fund projects. But they don't fund the glue in between them, the white space in between all those projects. Every staff person is a project director and a jack of all trades because they do this project and then they move to that project and then that project and that project. But the grant funding doesn't create the consistency over time. So we're going to be looking at additional revenue structures, including more philanthropic, core support, as well as membership. And I just want to say that our work is possible through the generous support and participation of folks just like you. It's really all of us. The coalition is your organization. And I can't take credit for saying this originally, but unlike Las Vegas, what happens in California doesn't stay in California. And I want to do a shout out to everybody here from outside of California and everybody who's watching us on live stream or following us on social media. We know that this is much bigger than California, and we know that we benefit from the work that is happening in other places, and we want to help this spread. But we do have some resources here in California. We have all of you that are here in the room. We have a lot of leadership organizations that really help us to move things quicker. So in the last few minutes here, I'd like to take some time. As Jim mentioned, there's a white piece of paper on every table. So if you would just gather together with the folks at your table and answer this question. How would you see the coalition bringing more value to you and your community? What can and should we be doing?